So just a little bit of history. Rush University is the oldest hospital in Chicago and one of the first medical schools in the United States. And this was the original Rush University right there, hospital. And everything you see in this one is now Rush. It's, I think, the second largest continuous medical center in the United States. Who would ever guess that? So I'm really glad we took a break because that panel is really hard to follow. And I got to tell you, I go to the Congress of Neurological Surgery, AANS of Neurological Surgery, and in order to get your CME credits, you have to answer their questionnaires. And their questionnaire always says, did anything you see change your practice? And the answer is almost always no. That panel just changed my clinical practice. So let's talk about the surgeons. Michaela and Jared said, they touched upon the horror of getting a spinal cord injury and being taken into the emergency room, and that their only goal at that time and for the next few days is to survive. Well, that's my goal too. So they give you their perspective. I'm going to give you the clinician's perspective on what we have to deal with when someone comes into the emergency room and the ICU with an acute spinal cord injury. So this is what we get when they come in, right? They're in this head holder to keep their neck stable, and they're on a hard board. Well, if you get injured in Timbuktu and it takes you 2 hours to get to the emergency room in the hospital, you got a sacral decubitus already. So our first goal is to safely get them off that panel while they're still within this thing. And then we have to keep them immobilized, we have to evaluate for pressure sores, we got to safely transfer the patient, and we have to get x-rays, we probably have to get a CT, and maybe we have to get an MRI. So we have to do a lot of moving with a probably unstable spine. Okay? And then, the obvious is the obvious. First things first. We have to make sure the patient's going to live, So airway, breathing, and blood pressure, cardiac, okay? So does the patient need to be intubated? Well, in a thoracic level injury, that's no big deal. Their neck is stable. But what about a cervical injury? Well, now it becomes an issue. What if it's a C1 or C2 injury? That's a big issue because they're really unstable, and somehow you've got to get an airway into that patient without injuring them further. So that's one of the first things we deal with. Next thing we have to know is what happened? How did this injury occur? Because that's going to give us clues as to what we're going to look for and what we're going to have to deal with. And then, so what are the forces, that cause this particular injury? That's going to tell us what kind of fracture there's going to be and what we might have to deal with. So, for example, if they get a compression on their head, it's going to give you one kind of, this kind of a fracture. If it's a distraction, it's going to give you that straight kind of a distraction. So the forces that impact the thoracic and the cervical spine give you different kinds of fractures, which means you're going to be treating them differently and looking for different things. For example, this is called a chance fracture, and it's through the disc space, the facet capsule, and the interspinous ligament back here. When you're looking at this on an x-ray, that doesn't look bad, but this is a really, really unstable fracture. So you won't want to be tricked just by that. Well, how do you know then that it's not? Well, a CT will give you indications that the soft tissues have been injured, so will an MRI. MRIs are controversial acutely in the context of a cervical spinal cord injury. CTs are not. How about this one? So this is bilateral locked facets. Okay, these are the facets right here, and you can see how nicely they line up there, and they're not lined up here, and that's what happens when that happens. But you never know. Within 1 week, I had a patient come in with bilateral locked facets who was completely intact neurologically, and I had a patient come in with just a unilateral locked facet who was completely quadriplegic. So it's never an all or none. How about a motor vehicle accident like this, being rear-ended by that big old truck? That's a hyperextension injury. It's going to tear the anterior cervical structures. It's probably going to tear the muscles holding your neck up. You can get a brain injury. It even can tear your trachea. So the mechanism of injury is going to tell us a lot about what we have to do acutely to treat the patient. So we really want to know exactly what happened. And then we need to know what this patient's past medical history is. Is this a drug abuser or an alcohol abuser? Does he have specific allergies? What medicines is he on? Has he had previous surgery? Someone who has had, for example, a 3-level cervical fusion who gets in a diving accident or a car accident, you're going to know exactly where the next injury is because it's going to be right adjacent to where he was fused. So it's going to tell you where to look. And what are the risk factors for spinal cord injury? Well, when they're in the emergency room, pain or tenderness when you're palpating along the spine, limb numbness or paresthesia, weakness, decreased level of consciousness, incontinence, being on drugs or alcohol, or do they have associated injury to their brain? So when they come in with the Glasgow Coma Scale less than 8, there's a 50% chance that they're going to have a spinal cord injury. How do we evaluate for that? Patient comes in with severe traumatic brain injury, so he's in a coma. So now you have a patient who can't communicate with you, who has potential spinal cord, and you have to figure out if he has that and what you're going to do about it. Well, you can do a cross-table lateral x-rays like this, and here again, another situation with bilateral locked facets. CT scan is going to look like that. You can see the facets locked right there again. And the MRI, after it gets reduced, this shows you where the injury is right there, but right now the spinal cord is not being compressed. So to do an MRI in a cervical spinal cord injury in the emergency room is controversial. You have to move them. They're going to be immobilized in a tube. So maybe you have to intubate them first. If they have a head injury, you definitely have to intubate them first. And the question then is, if they have, for example, this locked facets right here, we all know that the sooner you take the pressure off the spinal cord, the better the chances are for the patient. So do you reduce them in the emergency room, or do you go to MRI? Well, if you go to MRI, you're delaying reduction at least an hour. Why would you bother going to MRI? Because if they've got a disc herniation underneath the locked facets and you reduce them, you're going to cause further injury to the spinal cord. So you're sort of damned if you do and damned if you don't. What are the types of injuries that require special attention? Well, falls from significant heights, major rollover motor vehicle accidents, ejection accidents. Why? Because those people are definitely going to have multi-organ failure, not just spinal cord injury or head injury. They're going to have chest injuries, they're going to have abdominal injuries, and you've got to treat those things first because those are the things that kill you. Okay? Well, after all of that, finally we get to do an ASIA exam, okay? So we've treated all of these other things, and now we're actually going to examine the patient and see if he or she has a spinal cord injury and where that actually is going to be. But now we're in the emergency room, and we have to deal with emergency issues, okay? So the perfusion pressure of the spinal cord is equal to the mean arterial pressure minus the interspinal pressure. Why is that important? Well, following a spinal cord injury with a major accident, you can become hypotensive. There's different types of hypotension, okay? There is neurogenic shock, which means you have low blood pressure, a low heart rate, and warm extremities, and hypovolemic shock, meaning you've lost a lot of blood, low blood pressure, but a high heart rate, and your extremities are cold because you're not perfusing your extremities. So what? What's the difference? Well, I can treat hypovolemic shock with fluid replacement. If I treat neurogenic shock with fluid replacement, that does not treat the hypotension, and I'm going to put you into pulmonary edema. So I need to know exactly what I'm dealing with before we start treating. And what happens to low blood pressure? Well, you get down this far, and you're going to die. And that's why we have to keep the blood pressure up. We need to keep the mean arterial pressure up. We'd like to keep it above 80. Now, there's no empiric evidence that that's actually what we want to do, but over 50 years of experience, we've accumulated the experience that if we keep them at a mean arterial pressure of 80, they do pretty well. We don't want them to get below that. Well, what is neurogenic shock? Neurogenic shock is when you have unopposed parasympathetic action on the nervous system. So our blood pressure, our heart rate are a balance between sympathetic and parasympathetic stimulation, okay? The sympathetic system comes down the spinal cord, and it exits about T5. If we get an injury above T5, the sympathetic flow is stopped. Parasympathetics don't go through the spinal cord. They come down the vagus, so they're outside of the spinal canal. They're not going to get injured. So we have unopposed parasympathetic stimulation, which means you have low blood pressure, low heart rate, and all kinds of things that go along with that. In fact, you can even go into arteriovenous block because of that. So how do we treat that? So we got a patient that we think has neurogenic shock, and we know they're not going to respond to volume. Well, we start with volume all the time, so 1 to 2 liters, but if they're not responding, then we have to give something that's going to raise the blood pressure artificially. That's going to be like dopamine. So we're going to start treating them with something like that, okay? And then we want to be very careful with the fluids, or we put them into pulmonary edema. Well, so what is spinal shock? So patient comes into the emergency room. He's had a spinal cord injury. You've demonstrated that. He's got neurogenic edema. You're treating that. But when you get a spinal cord injury, you're supposed to be hyperreflexic, right? Well, they're not. They're completely flaccid. That's spinal shock. And that lasts a couple hours to maybe even a week or 10 days. So now they have neurogenic pulmonary edema, and they're completely flaccid. That's how you diagnose spinal shock. And they can occur at the same time. Now, so we get out of the emergency room, and we're now in intensive care. What are we dealing with there? Well, we were talking a lot earlier about autonomic dysreflexia. Autonomic dysreflexia is uncontrolled sympathetic flow output. So that's coming from, for example, a bladder infection, pressure on the bladder, doing a suppository. And so what happens is you get sweating, piloerection, flushing, headache, blurred vision, increase in systolic blood pressure. If that gets bad enough, that can put you into an arrhythmia as well. Okay, so here's pulmonary edema. So this is a patient with neurogenic pulmonary edema. We've overtreated them with fluid, and that's what it looks like. And now we're really in a tough place because they're not oxygenating very well. So why aren't they oxygenating very well? So when we get an injury, especially at C5 or above, our diaphragm is paralyzed. So we can't expand our lung capacity. But our intercostal muscles are also paralyzed, and our abdominal muscle is paralyzed, and we need them in order to evacuate the lungs. So nothing is working to inspire or to expire, and now they've got all this edema in their lungs. We're in tough shape here. If we start diuresing them, then they get hypotensive. So other respiratory complications, major cause of morbidity, pneumonia is a major cause of morbidity following spinal cord injury, and that's for the reasons I just explained to you. Bradycardia, both subacutely and chronically, causes supraventricular tachycardia or ventricular tachycardia. Mostly this occurs in the first 10 days while you're in the ICU, and it can be triggered by something as simple as suctioning. Okay, so if you've got pulmonary edema, you've got frothy airways, so we're constantly suctioning you, and that can cause bradycardia. So we can treat that with atropine before we suction in order to try and prevent that. Orthostatic hypotension. Now, normally our normal blood pressure, our mean is about 82. After spinal cord injury, it's really much lower than that, down to 57-ish. So if we stand up to transfer, for example, from a chair to the bed, and our blood pressure drops 20 more points, all of a sudden our mean is down to the 30s. That's in the range where you can die. Okay, so orthostatic hypotension is a significant problem, and it increases with sympathetic nervous dysfunction, with impaired baroreceptor reflexes. You don't have skeletal muscle contraction. Our cardiovascular system is now getting deconditioned because we're not exercising. We've got low volume and hyponatremia. All those things can cause and exacerbate hypotension. So right now, what are our alternative treatments for treating spinal cord injury? Decompression and or stabilization are our surgical options. Medications, steroids, antibiotics, blood pressure support, traction braces, rehab. Those are what we have available currently to treat spinal cord injury. Experimentally, we're looking at hypothermia, neuroprotective therapies such as anti-inflammatory agents, vitamin D and progesterone as antioxidants, or a variety of neurotrophic factors. A lot of pharmacologic attempts to treat it, methylprednisolone, for example, and riluzole, and we're looking at neuroregeneration right now. So we know that in order to get to clinical application, we go through this pathway. Somebody has a great idea, okay? I know this is going to cure spinal cord injury. So we go into an animal experiment, and we look at safety and we look at efficacy. If we get past that and we get to the point of a clinical trial, we're looking at the same thing. We're looking at safety and we're looking at efficacy. And then if all of that works, then maybe it will get to the point of clinical application. So that's a long way. That's 15 years, quite honestly. And let's say that you actually get through all of that stuff in the ICU, all of the stuff in the emergency room, and you become a candidate for a study. Okay, well here's our exclusion criteria in our last cervical study. If it was penetrating trauma, you couldn't be in the study. If you had anatomic transection or laceration of the cord, you're out. Any other concomitant injury that interferes with the examination, inability to effectively communicate, so a head injury, significant organ damage, history, malignancy, pregnancy, or nursing, if you were too fat, or if you were in another experimental protocol. So then you're out of the study, right? All right, so in summary, when we triage the patient, we're looking for keeping their neck neutral and stable, transferring to an emergency room bed. We secure their airway if necessary. We treat the hypotension, hopefully appropriately. We evaluate for other system injuries. Finally do a neurologic exam. We treat the most life-threatening injuries first. We examine them radiologically. If appropriate, go to surgery. And we manage all their systemic issues that we talked about: cardiac, respiratory, urinary, skin care. And we do counseling with the patient and family. If you get all the way through that, so you get through all the acute care stuff, you don't have any exclusion criteria, now you can finally be considered for a clinical trial, but you still have to satisfy all the inclusion criteria. And I'll leave it at that. Thank you very much.